Good evening. My name is Alexander Jones, and I'm the boss list of the Epsilon Iota chapter of Omega Psi Phi Fraternity Incorporated. Before we get started, we would like to take a moment of silence to acknowledge the passing of the 27th National President and CEO of Delta Sigma Theta Sorority Incorporated, Ms. Cheryl A. Hickman. Cheryl Hickman was a dedicated member of the Hartford Alumni Chapter. Her support of the Divine Nine organizations on a state and international level will truly be missed. We, the brothers of the Epsilon Iota chapter, express our deepest sympathies to our family and all the ladies of Delta Sigma Theta Sorority Incorporated. Our thoughts and prayers are with everyone who was impacted by this great loss. Amen. Thank you. We thank you for attending our Omega Uplift Series number 9. Variants, vaccines, a year later. Omega men are always hard at work as we continue to answer many calls around the community. COVID-19 continues to be a global issue. We thank our Social Action Committee for putting together this program to keep our community informed. While we are not instructing people on whether or not to take the vaccine, we are simply trying to provide thorough information through the professional expertise of our esteemed panelists in order for people to make an informed decision about the matter. Since the Omega Psi Phi Fraternity Incorporated was founded on the campus of Howard University 110 years ago, we have been guided by our 4 cardinal principles of manhood, scholarship, perseverance, and uplift. Omega has played and continues to play a vital role in the social and economic growth of our community, our country, and enhancing the lives of African Americans. As a fraternity, we operate under 10 nationally mandated programs, which are centralized around issues in our communities. Epsilon Iota chapter has been a staple by providing service to the greater New Haven community for over 30 years. Before we get started, I would like to share a few reminders. All participants will be muted during this presentation, but we do encourage your active participation by utilizing the chat feature. All questions will be acknowledged at the appropriate time. I would like to take the time and thank our esteemed panelists for agreeing to participate and give their expertise on this very important matter. I would also like to thank the Area Cooperative Educational Service for co-sponsoring this event with us. Our series moderator is a brother who plays many key roles in Omega, not only on the chapter level, but also on the district and international levels. He is no stranger to the greater New Haven community, where he serves as a head coach to the Wilbercross boys varsity basketball team. He is also a co-founder of Storytellers New Haven. He serves as a mentor to the youth, a leader amongst many men, and as an advocate for all. We hope you enjoy our program. I will now turn it over to our Social Action Chairman and our Omega Uplift Series moderator, Brother Kevin Walton.
And thank you, Brother Bosselus, for that warm and generous introduction. When we started the Uplift Series back on May 10th, 2020, I would bet that if we were still doing these community conversations virtually almost 2 years later, I would have lost a large chunk of change and we're probably looking for some place to sleep for the next couple of days. Yet here we are. But because we are men of versatility and because we are a resilient people, we will tap into our 4 cardinal principle of perseverance and continue to push through. On behalf of the Epsilon Iota chapter of Omega Psi Phi Fraternity Incorporated Social Action Committee, I would like to thank everyone for joining us this important community conversation this evening. You could have been anywhere else, but you chose to be here with us, and for that, we are grateful. The title of tonight's program, COVID-19, Variants and Vaccines, Where Are We a Year Later, is appropriate because it was almost a year to the day that we sat here with these same medical doctors who shared their thoughts on all things COVID. So it is with great pleasure that we reintroduce to our audience our esteemed panelists for the evening. We'll start first with Dr. Gary Desir. is the chair of the internal medicine at the Yale School of Medicine, chief internal medicine at Yale New Haven Hospital. He discovered a novel protein growth factor, which he named Renalasi. He is a scientific founder of two biotechnology companies. Born in Port-au-Prince, Haiti, after high school, he immigrated to the US to attend New York University. He was elected to the Phi Beta Kappa Society, graduated from Yale University School of Medicine, cum laude, Alpha Omega Alpha Honor Society. Dr. Deborah Desir. Graduate of Harvard University and Yale University School of Medicine. She was the founder of the Arthritis and Osteoporosis Center, PC. Currently an associate professor of clinical medicine in the Department of Medicine at Yale School of Medicine. She's the medical director of Yale Medical Hamden Rheumatology. She is on the finance committee for the Connecticut State Medical Society, and she is a proud member of the Theta Epsilon Omega chapter of Alpha Kappa Alpha Sorority Incorporated, and a member of the New Haven chapter of the Links Incorporated. And finally, last and certainly not least, is Dr. Tamiko Jackson Macarthur, a native New Havener who has been practicing medicine for 22 years in New Haven. She focuses on the health and well-being of her patients and their families. She is the founder and medical director of New Haven Pediatrics, located in the heart of the city. She is currently a member of the New Haven Board, a former member of the New Haven Board of Education, a former New Haven Health Commissioner. She's a Diamond Life member of Delta Sigma Theta Sorority Incorporated, New Haven Alumni Chapter, as well as a member of New Haven Chapter of the Links Incorporated. So again, thank you all for being with us this evening. And without further ado, we will go ahead and get started. So our goal this evening is to raise awareness and to provide information about COVID, variants, and vaccines, and to help our audience make the decisions about such that is in their best interest. The views of our panel suggest that they're personal and professional views and opinions. However, the information that you will see tonight will be based on science, experience, and medical expertise. But remember, the takeaway is that you are information that will help you make your decision. So, we'll jump right in. And I guess the question that we were talking about earlier, so where are we right now with COVID, and where are we headed, and what's next?
I guess that's a question for the panel.
Now, Dr. Desir and Dr. Macarthur.
So, okay, so I'll try, I'll begin. Well, first, let me thank the Omega brothers for having me here. It's really a pleasure to be here back again. I was, certainly none of us were looking forward to being here again, but here we are. I think that we've really learned that it's very hard to predict what COVID will do or the virus will do. But I can say that it seems like it's going to be with us for a while. So it's going to move from a pandemic phase to what's called an endemic phase, like the flu. So we get the flu almost every year. We suspect that we'll be dealing with COVID for the next many, many years. The great thing, though, is that the pandemic is changing, and it's changing for three major reasons. One, we have a vaccine, and we're going to talk a lot about that, I assume, a lot of questions about it. But I can say that it's very, very effective, very few side effects. Two, the drug companies are racing to develop drugs that you can take by mouth or by injection that can actually kill the virus. If you're an outpatient outside the hospital or in the hospital. And third, we understand how you get COVID, and there are ways of protecting ourselves. So overall, I think we're going to be dealing with COVID for a while, but we're in a much better place than we were, let's say, 2 years ago. And the question is, how do we get to even better place by following advice from public health officials, and can we do the right thing?
Thank you. I'll ask a follow-up question. So when you say it's going to be around for a while, it's going to end up being like the flu. So what exactly does that mean for us?
So if you remember, you remember the history of the flu, there was a major outbreak in the 1900s, early 1900s, and a lot of people died because of it. And then since then, every year, the flu reemerges because it almost never goes away completely because there are a few people who are infected with it. And then when it gets cold, people are indoors, it spreads more readily. The other possibility is that it can enter what we call different species, let's say cats or deer. Then it can live in the environment and then re-enter the human population. So there is a lot of evidence that COVID will be somewhat like the flu, where we will go down a lot and then we emerge at various times of the year. So it's very likely that every single year we may have one or two surges of COVID that eventually go down, just like we're having over the past couple of years. It goes up and it goes down, but that it will never completely go away. So we'll have to deal with it just like we deal with the flu. So in general, every single year, we have about, in the nation, 14 to 20,000 people will die from the flu. But a lot more people get the flu, but there are treatments for it, and most people get fairly mild symptoms. There is vaccine, and that's the way we deal with it.
And I appreciate that because, especially maybe like anti-vaxxers or people who don't believe in it have been saying for years that, oh, this is nothing but the flu. So it's been more than the flu, but as we go on, it may end up being something like the flu, like it's going to always be around.
Yeah, well, let me make a point there. I think when people say, well, it's like the flu, but remember, many people get vaccinated against the flu. And even with that, some of them still do pass away from the flu. And COVID is a little bit more virulent. That means it kills more people than the flu does. So even if it's like the flu, it's like a severe flu. And we can't just ignore it and say it's just like the flu, so we'll do nothing.
All right.
Also, so I think that just to add on to that right now, at least in the United States, and you can't necessarily extrapolate that to other countries because other countries have different access to the vaccine and different public health systems, but severe COVID right now that results in hospitalization, intubation, and death is largely a disease of the unvaccinated. So people think of it sort of bothers me a little bit to hear like the flu, because we're so used to the flu. We think, oh, that's no big deal. I'm going to get sick and I might feel like I want to die, but I'm not going to die. Severe COVID is largely a disease of the unvaccinated. So you are I think when people say like the flu, they just mean that it's going to be around every year. It's not going to go away. But I don't think they're trying to say and the flu is not necessarily benign, but it's certainly not going to be anywhere near as benign as the flu in the next several years.
And if I could piggyback on what Dr. Deborah Desir said, as that really kind of makes me wince a little bit when someone says like the flu also. And one of the things I like to help to understand how it's not like the flu, one of the most recent tallies of death from the flu in that 1 year, I think it was like 16,000. And remember, with COVID in less than a year, we had 500,000 deaths. So the word that Dr. Gary Desir used was virulent. You see how much how it's a lot more harsh when you look at a year of flu deaths, less than 20,000, less than a year of COVID deaths, 500,000. That's a big difference. So it's nowhere like the flu. So when folks say, oh, it's like the flu, It is not. And it is largely severe COVID where you're intubated and unfortunately moved to passing away. It's largely a disease of the unvaccinated and folks who have issues, have severe underlying issues that may compromise their immunity. And that also can be very bad for them. And that's why we're pushing booster, because the booster has really helped on that front. I know we'll get to that.
And can I also make, we will let you ask us questions at some point, but I also want to make a comment about something that the other Dr. Desir said that is so true. The pharmaceutical companies are working overtime to come up with treatments for COVID. But let me tell you something. If you were to go out, and I would just say, you can avoid breaking your leg, but don't worry about it. If you break your leg, we can cast it. You would rather not break your leg. And it's the same thing with pneumonia. We got plenty of treatments for pneumonia, but wouldn't you rather not get it? So I don't want us to get in our heads, well, we've got treatments for it now. I can't think of any disease where you're better off not preventing it. And this is no exception.
That's great information. And by the way, listen, the less questions we ask, the better off, because that means that you all are just giving us the information we need. So don't worry about it. So any one of you could jump in. So what do you say to those in the audience who are still vaccine hesitant for themselves? And I think for Dr. Gary Desir and Dr. Deborah Desir, and then for Dr. Jackson Macarthur, for your children, people are vaccine hesitant for their children. And I ask you that because you are a pediatrician. And so either one of you can start.
The vaccine is safe. And I think the three of us definitely agree with that. And we tell our patients when they ask us, should I get the vaccine? The answer for me, and I get this question a lot, yes, your child, if they're above the age of 5, should get the vaccine. It's a safe vaccine. It's going to protect them from contracting COVID-19. And yes, for the most part, pediatric patients do well. I have households where the entire family has contracted COVID-19 and the children are walking around like, oh, this is cool, I'm home. And the parents are gasping for air. Like, you see a real difference in the presentation. But what we don't know is if we just allow children to remain unvaccinated and contract the virus, get better, what happens later? COVID likes to give you issues later. And there are studies now that are looking at, will there be issues? I don't know, Dr. Gary Desir might have read about this. They're thinking that it possibly may be damaging the pancreas and causing diabetes down the line. And they're looking to see, is this something that is going to be an issue in the pediatric population? So as Dr. Deb Desir has said, why break your leg to get casted? Prevent yourself from contracting COVID-19 and having a very bad course.
Yeah. So I think the question was about why should one get vaccinated? And
those who are hesitant still.
Yeah. Yes. So people are hesitant. Well, I think Dr. Deborah made a good point already, in that she said that the people who are we seeing in the hospital are mostly unvaccinated people. So let me expand on that a little bit. So in this, we're dealing with our third wave right now, depending on how we count it, third wave. This is, I'm giving you numbers from Yale New Haven Hospital. Over the summer, we were having 40 people in the hospital with COVID. Then in October, it was about 100 or so. And then on December 24th, it was 200. And on January 14th, it was 450. Those are people who are being admitted to the hospital because they were really sick. You know, we tend not to admit patients to the hospital with COVID. We send them home, we give them treatment. And the people who ended up in the hospital, 90% of them were unvaccinated. Of those people, you know, like about 30% were admitted to the intensive care unit. And of those who were admitted to the intensive care unit, half of them had to be intubated because they couldn't breathe. And all of them were vaccinated. And our mortality is about 10% when you come to the hospital and when you get admitted. And most of the people who are passing away are unvaccinated. Now, some people who are what's called immunosuppressed, they're on medications that prevents them from reacting properly to the vaccine, also get very sick. But if you get vaccinated, it is possible to get COVID. That's certain, we see that a lot. But the severity of the disease that you get is so much less that it's almost not, you don't really need to be in the hospital. So if you want to protect yourself, I think vaccine is a good idea. Now, the question people ask is, well, is it really safe? Is the vaccine safe? You hear a lot of allergies and complaints and things like that. Well, I can say that the allergic reaction is small. Very few people get it. There are some people who get blood clots from certain vaccines. But if you look at the number of complications compared to how many people it protect from dying or being really ill, there is no contest. It's no contest. There is no reason not to get vaccinated. And millions of people have gotten vaccinated across the world. And we know, what the likelihood of a side effect is, and it's small. It's really small. And it's very, very protective against death, once you get vaccinated. So we've been discussing this for a long time. At the beginning, I could understand somebody say, well, I don't really know how the vaccine is going to work. Let's wait a little while to see what happens. Well, we've tested it. We've given it to millions of people, and it's very, very safe. So in my mind, there is absolutely no reason from a safety point of view not to get vaccinated.
So I'm sure everybody views their patients as special. My patients are special because they have, almost all of them are immunosuppressed in one way or another. Dr. Macarthur's patients, I refer to them as vectors of pestilence because they're the ones, as she said, they're infecting the whole household. And a lot of them are too young to get vaccinated. But some of the questions we get are things like, well, I don't know what's in it. And most of my patients are vaccinated, like 90. And part of that is that when they're long-term patients, they trust me. And they believe in what I'm telling them. So if I'm saying that I advise you to get vaccinated, the overwhelming 99% of them are going to go and do that. But I occasionally talk to people or run to a patient, and some of the questions are things like, well, I don't know what's in it. And I say, one of my answers is, do you know what's in monoclonal antibodies? Because if you get COVID, with your underlying illnesses, you're going to get monoclonal antibodies so that you can survive. And you have no idea what's in that. And so I struggle to understand vaccine resistance because most of us, none of us could go to kindergarten without getting about 12 different vaccines. And one patient, not one of my patients, but one of my partner's patients told me his answer to, she was off and I was on call and I said, this can't wait because this guy is struggling with whether to take the vaccine or not. And his answer was, but Tuskegee. And I said, this is really, really different than Tuskegee. In Tuskegee, they took patients that they knew were infected and knowingly withheld treatment from them for decades. And this was back early when the vaccine was first coming up. And I said, if you look right now outside of Harlem Hospital, there are lines of people who, this is probably the first time they ever went to Harlem because they came from this, surrounding Westchester County to get the vaccine. There were people, very wealthy people trying to bribe doctors in New York to give them the vaccine. This is the absolute opposite of Tuskegee, where poor Black people were denied care. In this case, well-to-do suburban people are fighting to get this vaccine. So these are some of the things that we discuss. And there are some people who will not be convinced. I have patients who tell me they're against it so one person told me she was against it for religious reasons. And I said, well, what religion is that? And I'm Catholic. And I said, you do know the Pope is vaccinated, right? And not only is the Pope vaccinated, you can't get into the Vatican right now today if you're not vaccinated. And isn't he your boss? And so she kind of laughed and went and got vaccinated because, you know, her religious, it really wasn't a religious objection. It was just, that was just her fallback. But as I said, there are some patients, and I'm sure you run into it, Dr. Macarthur, that you just can't, you're not going to be able to convince them. And you just have to hope that they don't get COVID. And because a lot of the cofactors that put you at risk for death from COVID are rampant in our community: obesity, diabetes, hypertension, lung disease, all of these things, you know, and occasionally it kills the young, fit, and healthy. It's a very, very unpredictable virus.
Yes, and I've had quite a few parents come in who contracted COVID-19, were really sick, were against the vaccine, and went and got vaccinated because they said, I wouldn't wish this on anybody. The gasping of air, the worrying about your children, having to try to take care of your family and be sick. And it's unfortunate that someone would have to get this infection in order to be convinced to get the vaccine. But that's what it has come to. And once you get the infection, the immunity you get is not superior to the vaccine, the immunity you get from the vaccine. So folks who are banking on that immunity, it's not going to protect you from another COVID virus that has the slightest of change. And a lot of them have the slightest of change. You're not necessarily going to get that same COVID virus again. So it's a false, it's just false confidence that you're protected once you get infected. But we got a comment from one of our link sisters who is an OBGYN, and she wanted us to mention Dr. Cynthia McCraven, that the American College of OBGYN recommends that women who are trying to get pregnant or pregnant and are breastfeeding should get vaccinated. So I wanted to make sure I said that.
Part of that may be because the drugs for treatment, almost all of them are contraindicated in pregnant and nursing mothers. So if you are at risk for a very poor outcome if you get COVID while pregnant.
And it is documented throughout the media unfortunately, of that type of situation.
I think you mentioned trust, and that's why it was important to have you all on with us again. That's why we're so grateful, because I think a lot of times, especially you talk about systemic racism across the board, but including in the medical profession, that us hearing this information from people that we know in the community and trust in the community goes a long way. And I would say that personally, we did this January 27th of 21, and I had no intentions of getting vaccinated. And then after we had this, I went and got vaccinated. And then, you know, and it was really because of the three of you and the information you shared and the way you presented it. So I thank you for that. So AJ, you want to, I think we do have a question. We have a couple of questions. So why don't we go to the chat?
So can I just make a comment about that? I think that the three of us care so much about our community. If you could have seen my husband when this all started, and he was showing me maps he had this map that was just unbelievable. Of they had blue circles where COVID outbreaks were, and you went up Whitney Avenue and there were no blue circles. You went up Dixwell Avenue, there were all these there were just, it was a sea of blue. This disease was killing us. And I think that if every time I mean, all my patients, I don't care whether they're white, black, I don't care what religion they are, it hurts me when I see unnecessary COVID deaths. I've had patients who, one woman's husband and son died of COVID. But I am so happy to hear that we said something that made you get vaccinated, because I feel that you're now so much safer than you were before we had that webinar.
Yes.
Yeah.
And how did it make us safer?
Because you are, if you're out in the community, because it's unavoidable. If you get COVID, you are very unlikely to die if you're vaccinated. That's how it made you safer. And it also made you safer in that you're less likely to spread it to people who are not vaccinated. My patients who are immunosuppressed are safer being around you, but you are personally safer. If you got COVID tonight, you are not likely to end up with a statistic on my husband's desk. And that just makes me feel good.
And you know, when we do these webinars or meetings, our hope is that we'll convince a few people, and then somebody will go out and get vaccinated, and that will protect them, that will protect their family. And that's great. It's really good to hear.
And AJ mentioned earlier that we're a co-sponsor tonight is ACES, the Area Cooperative Educational Services, where both of us work. And one of the reasons they were interested is because when we were doing vaccines, we do a vaccination clinic at ACES. But when we look at our numbers of students and staff who are not vaccinated, it falls again along those color lines of Black people are probably the less likely to be vaccinated. And then when we had the outbreaks, you know, a lot of folks were getting sick. So I think ACES and I appreciate them and understanding the importance of having this information to share with people within our community. So, yeah.
And it's not just, I mean, we've been talking a lot about people dying of COVID. It's not just death. And there are long-term sequelae of COVID that are very poorly understood, that we're just realizing now. And it's called long COVID. And we also see it in children. So there are children who develop cognitive difficulties and difficulty learning after COVID. Clearly, it's not every child who gets COVID. Most children who get COVID do just fine. But again, would you rather not break your leg? Or break, you know, we've got great orthopedic surgeons who can cast it. So.
Right. And you know, in looking at those lines, Kevin, around who's vaccinated, who's not vaccinated, we have a lot of misinformation. These forums are so needed because the misinformation is great. It's the social media. I had someone tell me that they weren't going to get vaccinated, and they did their research on Instagram, you know, and I was hurt because I was like, wow, people are really feeding this fatal information to our community, and we're listening. People are really listening. We have politicians who are supposed to have credibility, who are giving misinformation and who are feeding the misinformation that our community is listening to. We have to be careful to, one, not ever participate in any kind of misinformation. And if you hear of someone, a brother or sister who is not getting vaccinated because of false information, please correct that. Make an intervention. I have a lot more, well, I think I have a lot more, I'm gonna use the word tolerance for a vaccine hesitant person who says to me, I just don't want to get it, versus I don't want to get it because I'm getting injected with a chip, or I'm getting injected with HIV, or a lot of the misinformation that is really being fed to our people. So please check misinformation quickly. Don't allow it to grow, to fester, because the misinformation is one of the main reasons why we've seen such a large death rate amongst BIPOC folks who are contracting COVID-19.
And I think one of the reasons why misinformation is allowed to flourish is that, people don't know what source to go to. And so you go to the sources that we trust, information changes. And people don't understand that that's a good thing that information changes, because that's how science works. You get new data, you get new information, so you have to change what you say. I mean, the best example that pediatrician might appreciate is when I vaguely remember that when I was raising my babies, you had to put them to sleep on their stomach. Child Protective Services will come get you if you put your baby to sleep on its stomach now, because the scientific information has changed. And so therefore, the information that you give has to change. It has to be fluid. So for people who are skeptical because they said one thing about masks initially and now they're saying something different, that's because the information changed. And that's what you want scientists to do. And if they're not doing that, you need to not listen. And sometimes I just ask people, because I'm just like, I feel like banging my head against the wall when they tell me they do their research. I say, well, where's your lab? Do you have a lab? Where do you do this research? And it's hard because, you've got information coming from 10 different directions. You don't know what to believe. It really bothers me that a lot of the radio personnel and the TV personalities who are telling people not to get vaccinated have been vaccinated and boosted. So they're just telling you not to get vaccinated so they can continue to make millions of dollars a year, and they don't care if you die.
Yeah.
That is incredible. And I was reading something on the news this morning was just talking about how, people are just really dying just to keep one party in control and within power. But to your point, those leaders and those people spreading that information are very vaccinated and boosted.
And the governor of Florida, who has had a booster, will not admit to it. Did you have a booster? Well, is the answer that he gives on live TV. Okay.
All right. Good. If we can, AJ, you want to get to those questions, please?
Yes. John Lee asked, if it will always be there talking about COVID, then will the side effects decrease in potency as the years continue?
Well,
that's what we're hoping.
Yeah, that's the hope. So there is good evidence that that Omicron is a little bit less virulent than the original virus. The problem with Omicron is that it's so much more infectious. It's about 3 times, 4 times more infectious than the original one. It's almost as infectious as measles, which is really infectious. So that because it's so infectious, many, many people have contracted it and are going to contract it. And then if you're not vaccinated, you're likely to get severe disease. If you're vaccinated, you're likely not to get severe disease. So as the thing evolves, our hope is that it will become less virulent. But that will be infectious, and you still have to be vaccinated because you don't want to be caught being infected by a virus for which you're not vaccinated against. Just like we do for the flu. Every year I get a vaccine for the flu. I'll tell you my story about the flu. When I came from Haiti, I never got vaccinated against the flu. And then when I was in med school, I got the flu and I was in bed for 3 days. And since then, I've always been vaccinated every single year. So I don't want to get the flu again. And the thing to remember is that the vaccine may not prevent you from getting COVID, but it will surely prevent you from dying or being very sick. And that's really, really important.
With the new and thank you for that question, John Lee. So with the new variants, right? Will we have to get boosted, get another vaccine shot for every variant that comes out?
Well, depends on what it looks like. Go ahead, Dr.
No, I'm going to. This is a guess. We don't know yet. It is. So let's go back. Let's give you an example about the flu. So the flu changes every year. And then we the people making the vaccines guess what the changes are going to be. So they prepare a vaccine for the fall that based on some guess that what the variant will be. And I suspect that this might be something we do with COVID, and that we'll be guessing how it's changing. So for instance, right now, Pfizer, one of the main companies that makes vaccines, really good company, is preparing a vaccine that is specific for Omicron variant, and that will be ready fairly soon. They're testing it right now. So I suspect that every year, if it turns out to be the way we think it's going to be, every year there'll be a little change to the vaccine based on what we know is present at the time. And that's probably what will happen. The question will be, how long does the vaccine last? Do you need to get boosted twice a year, or maybe once a year, or every other year? We don't quite know yet. But that's the thinking currently.
And I think I've read that Moderna is working on a vaccine specifically for Omicron and Omicron variants.
Well, I'm sure they both are. Pfizer just announced that it is, but I'm sure Moderna is doing the same thing. Yeah.
Dr. Macarthur, so talk to us a little bit about the variants. So you said Omicron variant, so there could be a variant off of Omicron. Is that how it works?
So one of the things that the three of us probably just shiver when someone says variant, because that means that the virus is changing. So the first virus that came out, that virus is what change. Every time it changes, it moves away from what our vaccine recognizes. And as it moves away from what our vaccine recognizes, when you hear about a variant of interest, that means that we're concerned about the virulence of the variant and if our vaccine will hold against it. So when Omicron came, there was concern about the vaccine strength against it. And that's when they said we should boost, because we want to get our levels up, right? Our antibodies as high as they can be to fight that variant. So that's when we start saying we need the booster. If you're 5 or 6 months out, please get boosted, because the studies showed us that the booster will raise your antibody level and help you to fight the Omicron variant. Now, as Omicron lives and continues to make more Omicrons, and people are coughing it out and sniffing it out, it kind of like it's living its life. And I'm saying it's living its life, it's doing its thing, it's infecting people. And then it's like, but hey, I think I've been acting the same a little bit too long. I need to switch it up a little bit. I'm going to switch it up. And that's what a variant is. It switches up a little bit because it sees that it's been here a little bit too long and it wants to live. So it'll switch it up so that our antibodies might not be able to fight it, and it can live longer and it won't be stopped. So that's what a variant is. It's a little change that allows the virus to live. And so we don't want variants. People who aren't vaccinated and they contract COVID-19, they literally allow the virus to replicate more than what would happen in someone who was vaccinated. And that's why we're afraid. That's why we don't like the fact that unvaccinated people continue to remain unvaccinated, because they literally are helping the virus to live, helping the virus to grow, to change. So every time the virus changes, if it causes issues and makes people very sick, we consider that a variant of interest. And right now, that's why the different companies are racing to see if they need to make, or not see, they are making vaccines against the Omicron variant and variants off of Omicron. And if we're seeing that, that means that the scientists that are on the front line working this, they're thinking that Omicron is going to be here for a while, and that Omicron is going to be the daddy of a couple of different variants that we need to be protected against. I mean, that's how my mind looks at it. I'm not Dr. Gary Desir. As far as these variants, does that sound right to you? You are my lab person.
I'm like terrible with sports analogies, but I'm going to tee it up and toss that one to Gary.
Yes.
I think you're correct, Dr. Jackson Macarthur. So just so you know that every time the virus multiplies, it mutates a little bit. And the reason for that is that it doesn't have good correction system to keep it from mutating. And then sometimes the mutation make it live longer or not. And if it lives longer, then it mutates some more. And so we're seeing variants all the time. Every time we test, there is a new variant. But not all of them become important because some of them just are not fit to infect a lot of people. So you got the initial one, there was Alpha, then there's Delta was pretty strong. And then all of a sudden, Omicron took over Delta over about maybe a week or so, 2 weeks. So we went at Yale, we went from 90% Delta to 90% Omicron over 3 or 4 weeks. So Omicron is a much fitter virus and it can infect more people. But it's a little bit less virulent. But because it's infecting so many people, we see a lot of disease and death. And I suspect it will continue to mutate. What Tamika said is that if you are unvaccinated, you're kind of like a test tube for the virus because it can multiply for days, for weeks in you, for months sometimes, so that it has a lot of chance of mutating and becoming fitter. And that mutant goes into the population and then takes over. And they think that's what happened with Omicron. There was somebody who was immunosuppressed, was infected, had the virus for a couple of months, and then it mutated enough to go out of the population. So the way to deal with that is really to get as many people vaccinated as possible to reduce the chance of the virus when it multiplies, not to multiply enough time to become really mutated and really fit to infect other people. So it's a race. It's a race all the time against multiplication of the virus, and vaccination is the way to prevent that.
So look, 2 questions, right? So does that mean where are we with the Delta variant? Right? Is it still here? Is it still around? And how far out do you, as a scientist or whoever's working on it, how far out do you see something that may be problematic?
So there are laboratories all across the world that sequence the virus all the time. And then they're looking for changes in the virus and they can classify what they look like. So for instance, Delta, there are sub-Delta variants. Omicron, there are sub-Omicron variants, and you track them and you see what happens in the population because we like a big test tube. And what they will look for is let's say right now there's Omicron. We know what the sequence looks like. And then what they're looking for is sequencing people who get infected and looking for new different variants and then how they compete with Omicron. And we've seen probably 100, 200 variants over the past several years. But only a few of them are good enough to infect the entire population and to cause disease. And that's what they're looking for right now. Currently, we see very, very few Delta cases, very, very few. It's 95% Omicron. And what we're looking for is there anything else beyond that can become stronger than Omicron and take over? And then we have to focus on that one because the antibodies you made before may not be effective against this particular variant. So it's always there is always it's like a detection process that's in place all the time.
Correct me if I'm wrong. Do we say it's less virulent but more infectious?
Yeah.
So what exactly does that mean?
So what that means is that if your chances of getting Omicron is 4 times higher if you have a person infected than the chances of getting the original virus. So 4 times, it's much more infectious. But the data so far indicate that if you get it, your chances of dying is a little bit less than compared to the original virus. But from a population standpoint, what it means though is that we have 4 times more people infected compared to the original thing. So just by statistically, you'll see a lot more people get really sick, a lot more people getting in the hospital. So what we saw in the first wave is that it took about a month or 2 to get to the peak of the hospitalization, while for Omicron, it took 2 weeks to get from beginning to end of the peak. So a lot more people getting disease and a smaller percentage getting really sick.
Can I just
modification? Yeah. Yes, please.
So translating that means that more people will die even though it's less virulent because so many more people have it.
Right.
There's a question in the chat that I'm going to try to answer real quickly because I think we're coming to close. The question is, what type of treatment is given if you're diagnosed with COVID? And I need the other two to chime in. And right now, there are basically 2 types of treatments. One is antibodies, monoclonal antibodies against the disease, and the others are, and those are the ones that are frantically being developed now, antiviral, things that actually attack the virus. I don't know if anybody's ever had zoster, shingles. You get Valtrex, that's an antiviral medication. So antivirals are being developed.
Tamiflu.
Tamiflu is another good example. The difference is that these medicines, they have to be given early on in the, almost immediately upon getting it, and the availability of testing is a problem. And the other thing is that some of them are not active against Omicron, so they're useless against Omicron. Others are, they interact with a lot of the medicines. Again, the people who get this and are at risk for being sick are people with what we call comorbidities, other illnesses. So you might have to stop all your other medications for the 5 or so days that you're on these medications. And the other issue, which we've already touched upon, is they can't be given to pregnant women and nursing mothers. So I don't know if the other 2 doctors has a comment.
So I'm working with I've been working with a group that is using the pills, the oral treatment within 72 hours of symptoms, and it has definitely helped. I've seen it turn someone around that fever. I was going to say hyperpyrexia. I mean fever, 104, coughing, the GI issues, and treated within 72 hours. And I saw all those symptoms effervesce and was able to tolerate the course well. But had it not been for that pill, I think the outcome would have been a lot more severe, and who knows what else would have happened. So there are treatments, but, and I am going to use this all the time now. Why do you want to you don't want to break your leg to get a cast, you know? You don't want to break your leg. I love that. I'm using that now.
I want credit.
Yeah. So well, we could talk about a little bit about prevention, right? So I don't think it's, you know, it would be out of order to talk about prevention, but can we talk a little bit about, so you have these pills coming, we have these medicines, this treatment coming. Can we talk a little bit about the affordability of it, right? Is it going to be affordable, or are we going to be in that kind of skyrocket medical price where, you know, folks who can't afford medicines lie?
That's an easy answer. Yes, that he's going to be unaffordable, but the vaccine is free. You don't even need to have insurance to get the vaccine, okay? It's been free from the beginning.
Yeah. You know, I think that
in 95 masks are free, right?
I think that it's going to be affordable because this disease is just ridiculous. COVID-19 is just killing so many people that I mean,
yeah,
just like in the beginning, like, you know, it wasn't picking and choosing certain people. It kills people no matter who you are. So
choosing us.
Well, fact, right.
I'm not a conspiracy.
You're right.
I'm not.
Well, I agree.
Theorist,
I don't.
But I really am not a conspiracy theorist. But somebody keeps telling me in the beginning when it looked like it was just going to kill Blacks, Hispanics,
Indigenous.
That's why the administration at that time didn't. And in fact, one of them clearly thought that it was just going to affect blue states. I don't know why. And so, no, seriously, Jared Kushner said that it's only, we can leave it alone because it's just going to affect the blue states. But I think there were probably others in that administration who saw it was initially killing us. It is killing us. And so they paid less attention to it initially.
But now they see it kills everybody.
Yes,
I think the pills will be affordable with insurance.
But the pills,
I worry about the uninsured.
I'm looking at but that's healthcare in America, right?
Yeah.
But you know, also the pills are not widely available right now.
Not yet.
There's a shortage, and they have, you know. So I agree with Dr. Deborah that we should focus on, you know, we should try not to get it. You know, prevention is a
don't break your leg to get a cast.
And I'm looking at a chart right now because we had rheumatology grand rounds on COVID in our patients this morning, and the pills are not like 100%. Your patient still could have died. The person you were working with still could have died a horrible death. It's not good not to breathe, not to be able to breathe. The risk reduction is not. It's not. I'm not impressed. I mean,
and you know, it just over the last, I would say, I'm going to say month. Over the last month, we have experienced at least a handful of people in our area who still died from COVID.
Yeah.
You know, this is still happening. And, you know, I don't know what people's vaccine status was, but I know that we're still having COVID deaths. So, you know, prevention is the key. And, you know, the medical community is getting fed up with folks who don't want to get vaccinated. I just read an article today in the Times where there's a young man who should be getting a heart transplant, and he is being denied his heart transplant because he will not vaccinate. Because if you don't vaccinate and you get a heart and you catch COVID, what's going to happen?
Well, I think that there are a lot of transplant centers that won't, because you have to go on impressive immunos. You know, on TV, you get the heart and now you're cured and you live your life.
Exactly.
In reality, you're on powerful immune suppressive drugs for the rest of your life. And so
they're not playing. People have to get vaccinated.
But the other part of that issue is that if I leave, well, I'm home, so not if I leave here, but if I'm driving somewhere tomorrow and I get in a car accident, there's not an ICU bed for me. If somebody on this thing has a heart attack tonight, they're sitting in the ER for 30 hours because there's not a cardiac unit bed for them, because it's full of patients, unvaccinated people with COVID. So I think that we've reached it's for however briefly a free country and everybody has freedom of choice, but we also have an obligation to our communities. And it's not just for you, it's for protecting your community and making sure that the hospital is not full of unvaccinated people with COVID, so that if your child gets hit by a car while riding his or her bicycle, they don't have to die in the ER because there's no staff in the operating room and there's no staff in the pediatric ICU. And all the beds in the pediatric ICU are full of sick kids with COVID.
Mm-hmm. And as far as the care that you're getting, you know, the medical professionals are wary. They're wary, they're tired. We've lost brilliant minds to COVID who were there in the beginning, who were on the front lines, nurses, doctors, anyone that's worked in the hospital, you know, have been majorly affected. And there are things that we will never, ever forget around treatment and the treatment of our patients during this pandemic. You know, it's a lot. It's a lot, and we're continuing to support the community, but you know, if folks aren't going to get vaccinated and we continue to have these surges that are primarily with people who aren't vaccinated, you know, you can't. Something has to give. You know, something has to give, and the data is there that this vaccine has saved hundreds of thousands of lives. It's not thousands, hundreds of thousands of lives, you know. Get vaxxed.
Something Dr. Deborah Desir talked about, because I read, you know, on the news, read reports about people were actually saying that, you know, that hospitals shouldn't treat people who are unvaccinated because, like you said, it's interfering with other medical procedures and stuff like that. I'm not sure if I'm there, but again, I think, so how do we continue to because I think it speaks to your point about us being communal, right? And trying to take care of each other and the reason why you want to get that vaccine. Okay, so we have about 20 minutes left. And
I can,
yeah,
I was going to comment on that I'm not there either. I think, you know, we should treat anybody who comes for treatment, but it's almost like when you use up all your resources and there's nothing left, what can we do? So I just read that I think it's Idaho that basically sent that horrible letter out that we've seen in other states where they're almost like certain people, they can't do anything for certain situations. It's almost like rationing out care because they're hard hit out there. I think they're hit harder, a lot harder than we are right now. But, you know, institutions are running out of oxygen. They're running out of beds, like Dr. Deborah Desir said, and getting to the point where your resources are so taxed that you run out of things that we would always have. We never run out of oxygen, but there have been hospitals that have run out of oxygen.
Think of it, everybody's been in a store recently where there's been an empty shelf. And they claim it's a supply chain. I don't really know what it is, but you know, I went to buy some pasta the other day and there was like no pasta. So I don't think we're going to be at the point where I think that emergency care will always be available, I think, and I hope. But I think that as we we are literally running out of resources, and our biggest, most important resources are healthcare workers. People are quitting in droves because they can't take it anymore. People are finding other things to do. So you can have 20 beds in your intensive care unit. If you only have 4 nurses, you can only staff 2 of those beds. So we're running out of resources. So I don't think we're going to get to a frank denial of care, but it's going to be a practical denial of care. And that really worries me, because if you look like me and you arrive at the ER, you look like somebody else, who's getting the care if it's scarce? It ain't going to be me.
Absolutely. Absolutely.
So
when I did my renewal of my BLS, the paramedic came in and was talking about the things that they're doing right now. And ever since COVID with, when paramedics or EMS come to your house, if they on the phone talking to a doctor, they can pronounce you now. I had never heard of that. And they said it was because of everything with going to homes with COVID, people who were so sick with COVID, that they weren't necessarily bringing them to the hospital. And I was floored. And I was like, what? So someone could come to my house, not a doctor, talk to whoever the doctor is at the ER, give them what they perceive is the situation, and they can get permission to pronounce somebody. That's scary.
There's a very interesting question in the chat from Anthony Charles, and I'm going to try to answer it, and then you guys please chime in. I think it says, why aren't antibody levels considered in the data? For instance, if a person gets vaccinated last June and aren't boosted, but a person who's unvaccinated and were infected in December and recovered, wouldn't the unvaccinated person have higher antibody levels? And the answer is not necessarily. And I think the reason why antibody levels aren't considered in the data is it's not 100% clear what they mean, because you have cells in your body that remember what bug you saw or what virus you saw, and then they make antibodies on demand. So you could conceivably have a low antibody level and still have a lot of protection because you've been vaccinated. So we're not yet ready. I mean, if you have no antibodies at all, then our concern is that the vaccine that you have no immunity. But what varying antibody levels mean, we don't really know. And Gary, I'm going to toss it to you again.
Right. Yes.
So I think that's a really good question. I mean, two things. One, there are studies that show that if you get infected with COVID and then you get a vaccine, the immunity you develop is much longer lasting than either the vaccine by itself or the infection by itself. So the infection, we know in most people, if you get infected, we know that the amount of antibody you develop goes down over time, lasts maybe 4 or 5 months, and disappears. But if you get a vaccine and you've got an infection, the type of antibody you make and the duration is much larger. And the other thing is that not all antibodies are the same, and that's what Debbie mentioned. Some antibodies actually don't do anything. They're just there. They don't prevent you from the virus from infecting your body because you just make a lot of antibodies. The vaccine is specific for certain parts of the virus that are important in the infection process. So it's a bit more specific than just general infection. So the combination of both is better than just either one. Now, I'm not saying you should go get COVID and then get vaccinated. I'm just saying that if you get COVID, it's not a contraindication to being vaccinated. It's actually better. You get a much more durable immune response than either one. So not a contraindication. Well, the timing of boosters, I think, again, is actually fairly empirical right now. And we do know that people who get vaccines, the antibody response also wanes over time. So the decision is, I don't know, 6 months or whatever, but it's not precise. It's not as precise as one would believe. But you do need to get a booster.
And I don't think we know yet how many boosters. I think we should get into our heads that we are going to be getting boosters. I mean, we don't think of an annual flu shot as a booster.
Yeah.
But we get annual flu shots. And except for people who think that flu shots give them the flu. And I spend a lot of time trying to explain to them, that's not possible because it's dead. But so I think boosters are here to stay. And especially as the virus is mutating so rapidly and companies are having to come up with to make sure that whatever the current version of the vaccine is covering whatever the current variant is.
Could we talk about masks, Kevin, at some point?
Yeah, let me just, I will get right to that. I just want to ask Dr. Deborah disease. So when you talk about booster and compared to the flu shot, so is it really about kind of the language you're using, and would it be like if we're just saying we're getting a booster or a vaccine shot?
And especially for our patients, because again, I said our patients are special, they're immunosuppressed. We do not think the third shot for our patients is actually not a booster. We don't consider them to be fully vaccinated until they've had 3 full injections. And then for the Moderna vaccine, a booster is, so I'm presuming you're not immunosuppressed. So when you go for your booster, if you had Moderna, you're going to get a half dose of Moderna. And that's going to be a booster. The Pfizer, there is no booster. It's this, when you go for your third shot of Pfizer, it's the same, exactly the same amount that you got the first time. So you're probably right. We're probably loosely not using the language in a very precise manner. So whether you think of it as a shot or a booster, you should, by now, everybody should have had 3. Mm-hmm. Anybody who hasn't had their third, what did you say?
Regardless what you call it, you should have had 3, huh?
Exactly, right. Exactly.
The one exception to that, because there's always an exception, is that if you got Johnson & Johnson, which was 1, all the comedians are joking about now, the Johnson & Johnson, like that's the Walmart of whatever. But if you got Johnson & Johnson, you just need 1 more to be, because it was 1 to begin with, so you need 1 more. And the recommendation is that you can get another Johnson & Johnson if you want, but the recommendation is that you get one of the mRNA vaccines, either Moderna or Pfizer, if you got the 1 Johnson & Johnson.
Everyone else 3.
Wait, we missed, like when you first start talking, we missed the first part of your sentence.
I'm not sure. I'm sorry. But how about, so I think I thank you for that explanation. So I think if we move a little bit, Dr. Macarthur, you wanted to talk about masks.
Yes. So we just had a mask update recently, and I think it's important just to touch on that. And I think the take home for that is that the facial material that people are wearing versus the tubes or the material or anything like that is not recommended anymore. It's recommended to use if you can, a KN95 or an N95.
And also the Korean one.
Which one is the Korean one?
The Korean one is, I think it's called the FK94 or something like that. It's a Korean. N95s are American. KN95s are Chinese, and FK94s are Korean.
Right.
And cloth masks are out. They're not, except
it's like wearing nothing.
Except unless they're a cloth mask where you put the insert in. So if you have a cloth mask with the insert, because it's the treatment of the fibers in the non-cloth masks that are stopping the virus. So right. There are cloth masks that have a little pocket, and you put like N95.
Those filters or whatever.
Put N95 filters in them. Those are probably okay. But my little granddaughter used to have this thing around her neck that she pulled up, and we had to tell them stop. And surgical masks, which we all used to wear, are, until we get past this Omicron peak, if you can at all possible get a KN95, it's better than the surgical mask, because the surgical masks are too loose. And I've heard that they sell something that holds them closer to your face, but I haven't seen that. So it's not that the surgical masks are bad or not effective. It's just that there's too much air, too much circulation around them.
Right. Because people aren't pinching them.
Right.
So they're just,
But the size too.
Right. And if you want to keep your style, you can always pull your tube over your KN95 if you want to keep your style. So, but you want to wear KN95 if at all possible, or N95.
I think
I wear N95.
I thought the governor was giving everybody 3 N95s. Is that true?
I haven't found out how to get them yet, but apparently the drugstores are going to have them too. And someone said Friday, but I'm still kind of trying to find out from DPH how we're getting them.
I mean, that would be important to know, because I think everybody should be wearing them. And the reason is because Omicron is so infectious that you need to wear a mask that is more protective. That's the main reason.
Yeah.
So yeah, until we get past this Omicron, and I don't know what to do about children, because I have not seen any child-sized KN95s. So they're stuck with it. There are child-sized surgical masks. And
what they can do for the kids whose faces are a little bigger is if they kind of fold over on the KN95, fold over the little metal nose thing. If you fold it over, it will help to seal.
Okay.
That will help for not the babies, like not the 5 and maybe like the 8, 10-year-olds, and their face is still small. If you fold the metal piece over, it can help to bring a seal around.
So one thing I forgot to mention about pediatric children is that for this wave, we're seeing a lot more kids in the hospital,
yep,
in the ICU than the first wave. A lot more kids. And it's just because so many more kids are infected that we're seeing some of them being admitted to the hospital.
That's a perfect segue into what's happening with our schools. So you see all across the nation, and the mayor with all the swagger in New York, he first came out and he talked about kids were going to stay in school, and there was a spike between his administration and teachers, and so teachers are adamant about not going into school. So just where are we in terms of schools opening, kids attending school? Are we headed for another shutdown? I know Dr. Macarthur, Tamiko Jackson, you had lots of experience on your time at the Board of Ed, so I will go to you first.
So yeah, we've seen a lot. I mean, I have Chicago's teachers walked out, and they were battling with their mayor and their superintendent. But school works with the right mitigation. If they're wearing masks, if they're distancing as much as they can. And one thing we've also found helps is their testing. So masks and testing are key. Even if it's the Binax, which we've had flooded into our community recently. So what we're finding is that the pockets, the kids that are exposed, or that in the tracing of the positive case, they quarantine if they're exposed, isolate if they're infected. I don't know if we're headed to a shutdown, honestly. It depends on what the numbers are and how many infections present. But I can tell you this, that I'm just going to say from my experience, I don't want people to say I was talking about New Haven Public Schools, because I'm not. My children experienced a lot of substitutes because there were a lot of infections, of course, because the community, at one point we had a 25% infection rate. So a lot of teachers were out, a lot of students were out. And the only thing you can do is continue to test and wear masks. And one thing about in New Haven is they are pushing masks and they're pushing testing. So that's the only thing you can do. I hope we don't get a shutdown. Shutdowns were horrible. We have a learning loss. We have children who were home alone. A lot of children relied on our school for food, breakfast, lunch, and in some schools we had a supper program. So we don't need a shutdown. We need mitigation factors that are working, and for the districts to continue to use those mitigation factors. New Haven is good. But, you know, you have some communities that are like, unmask our kids, you know, all this stuff that they're saying. That's a problem. And I would worry about those schools. But New Haven's doing pretty good.
To that point, I don't want to see another shutdown either, because I think what happened as being in the education profession, I don't think our industry was prepared for the lack of social emotional learning that our kids were missing during that time. And so if you heard about all the stories about kind of the behaviors that were happening in school, but the interesting thing is that we may put it all on the kids, but there were a lot of adults who were suffering as well. So to all of those points, the need for us to remain in school, but to be safe and do it safely.
We haven't seen the mental health issues that we haven't seen it, all of that yet. I think that's still building. Things are still surfacing, but a lot of people are struggling right now.
Family, so we have to kind of continue, and again, it goes back to that communal piece and trying to take care of each other. So can you all speak to us a little bit about kind of the CDC, what's going on with the CDC, right? Like, I think now it's, you know, you hear the jokes, people say the CDC said, you're just on your own, just figure it out, right? But in terms of getting back to, you know, if you're diagnosed, if you're exposed, sometimes they say it's 14 days and 10 days, now 5 days. Where are we in terms of kind of quarantining and being able to return back to work or school or wherever we're going?
So I think that the CDC tries to gives guidelines that they believe are useful and can protect people. And the reason they decrease the quarantine numbers to the suggested 5 days, so they can force you to do it, but they suggested 5 days, is because we were facing a severe shortage of healthcare workers that we could not, if you couldn't bring people back, you know, if they're feeling okay after 5 days and you don't have anybody to provide care in the hospital for patients. So that's a problem. So I think the CDC was driven by this problem that we're having across the country and in New Haven and in Hartford and, you know, other states, that we were running out of people. So if you know, Tamiko mentioned that the infectivity rate was 25% in New Haven, in Connecticut. That means 1 out of 4 people had COVID. So if they had to stay out for 10 days, then who comes and provides care for the patient? So that's what they were saying. And then there is some data that at 5 days, maybe you're much less infectious than you were at before. And then if you're wearing an N95 or KN95, whatever mask you wear in the hospital, your chances of giving it to somebody else is very small. So that's a decision they made to help the country have some guidelines. But many places did not follow that. You know, Yale New Haven did not follow it because they felt that they could work with 7 days as opposed to 10 days. So that's what many places are doing. So I think they were giving you the lower limit of what's acceptable, and then you can work at whatever level you want.
Yeah, I agree with Dr. Desir. You know, they're guidelines, recommendations, and that's exactly what they are, recommendations. They're not hardcore, you have to do it like this. Yale New Haven said 7 days, but places where there's congregate living, a lot of those stayed with the 10, because, you know, because of the infectivity of Omicron, they chose, hey, you know, someone getting the infection in a congregate living situation is going to be an issue. So we're going to stay with a longer isolation and quarantine. Yeah. So the CDC, people are like, even myself, sometimes my head spins with the CDC, but they are guidelines, and that's all they are, guidelines. You have to take that and apply it to what is clinically happening where you are.
And also they also have to respond to changing science and changing facts, and none of this is static. I think that the worry about the CDC is sometimes they may be responding to politics and not science. And we all wish that they would not do that, because we need them to respond to science, and we can all respond on our own to politics.
And I do appreciate that, because that was going to be the question I posed. Was it that is the CDC, their guidelines now being politicized to kind of make it work for one side or the other?
I don't think so. I think that this was actually
economics.
This was, well, I mean, this would benefit both red states and blue states, because it was a matter of healthcare, manpower, and women power. And it was an emergency, and they thought that that would help. And that would allow people to use whatever guideline, whatever number they want to use, but they give you a floor of what above which they felt it was safe.
Clearly and precisely, maybe you should be the next head of the CDC.
For that.
You know, I lost half of my hair. I would probably lose all of it if I became the head of the CDC.
No, he can't go. He can't leave New Haven. He's got to stay in Connecticut. No way.
Yeah.
Well, so listen. So I think we've covered a lot of topics. I think this has been a tremendous information sharing session. I just want to I would like to give you all a last word that you want to share with our audience. If you have a quick question, you can drop it in the chat, because we can stay for a few more minutes, but I want to give our panels the opportunity to give us a last word. You know, this has been tremendous. So grateful, but so please close us out.
I say ladies go first.
I can't promise this will be my last word, but but I do want to say something that really has very little to do with the pandemic. I often talk to people who are not Black, and they don't, if I say I'm in a sorority, they say, huh, isn't that college? And I have to explain to them about the Divine Nine, and I have to explain to them that historically Black sororities and fraternities are active for life. And we serve, you know what our motto is, service to all mankind. And we do public service and community service. And I just want to thank your chapter of Omega Psi Phi fraternity for the wonderful work that you do. And thank you for the opportunity to sit on this panel. But I'm not promising that's my last word.
Yeah, well, you know, you're the boss. So anything anytime you jump in, please.
I also want to thank the brothers of Omega Psi Phi. This is by far one of the, I had a lot of fun, and it kind of reminded me of last year, because it flowed and we were able to give this information to the community. And I wanted to also, Dr. Deborah Desir thanked the Divine Nine, but I also want to also recognize the Links Incorporated, National Transit Services, who worked with you on this. And there's a bunch of links from different chapters, even from Massachusetts, up on this webinar. So I'm glad that they got on. And the Links is also historically Black women's service organization, and they also work to get critical information out to our community and to keep everybody educated. But I want to thank you guys. This was wonderful, and I really appreciate that. And thank you to the Desirs. I love serving with them.
So just so Tamika doesn't get me in permanent trouble with the Links, I just want to say that the Links have been on this from the very beginning. We were getting masks to the communities when nobody could get masks. Gary had some kind of secret and was able to get masks, and we were handing them out. And two older women, the names are escaping me right now, were just phenomenal. So to my Link sisters, you're wonderful, and you're out there in the community every day. And shout out to the girlfriends, just so I'm just trying to stay out of trouble.
Come on your faces.
Well, I want to thank Omega Psi Phi for inviting us again, and for doing the work they do, which is really very beneficial to all of us in the community. What I would like to say is that I hope that this has changed a couple of minds here, and that you would go out and change a couple of more minds, and we can save a few lives. And the more we do that, then the better off we'll be. So I hope that that's what I hope for tonight.
And thank you to Tamiko, who always makes sure that I answer her emails and say, yes, I'll do this.
Yes.
We are so grateful.
I want to thank the audience also for participating,
Yes.
and listening and being there.
And great questions from the audience.
Yes, yes.
We're engaged, so hopefully you spread that message. If you're not vaccinated, hopefully you heard some things that help you change your mind. And if you are vaccinated, and go out and talk to people who still might be hesitant. Before we go, I just want to just again thank our panelists, Dr. Gary Jazier, Dr. Deborah Jazier, Dr. Tamiko Jackson, Macarthur. On the call, I see is the Assistant Executive Director of ACES, William Rice, who's in charge of schools, and he was very instrumental in getting ACES connected to this program. So I just want to acknowledge his presence as well as everybody else in the audience. And of course, to our Executive Director, Tom Dennehy, and our Marketing Coordinator, Elaine Zane. So, but thanks to our sponsors, ACES, and in conjunction with the National Trends and Services of the New Haven chapter of the Links Incorporated, I had that, Tamiko. Our sponsors, our panelists will be receiving a gift certificate to Gather at Bloom, a community gathering center located at 794 Edgewood Avenue in New Haven. If you haven't been, it's a beautiful space. It's a boutique. Yes. You get flowers, gifts, health and wellness. They have a cafe, an event space. It's a happening place in Westville. And so, you know, that's our gift to you all for giving up your time and service.
Thank
you. Thank you. Thank you so
that
much.
place is so nice.
Very much appreciated. Yeah.
Thank you.
Thank you all. You've been a wonderful audience. Please stay tuned for our next Uplift Series event, which will take place on what day is that, Brother Basilis?
Ooh, that's gonna be good.
Oh, that's gonna be February 23rd. It's a Wednesday evening.
Critical race theory. The real story. We have a strong panel that will be there for that. And so I will have Professor Jonathan Wharton, Judge Angela Robinson, and Attorney Michael A. Jefferson, who will be our panelists for our next Uplift Series, which is February 23rd. Thank you, and stay tuned. We'll continue to do that. We thank you for being here, and have a good night. And thank you to our panelists.
Thank you. Bye, everyone. Stay safe.
Thank you.
Vaccinated.
Night. Brother, we staying on, or we're gonna jump back on? I gotta eat.
I thought we were staying on.
Stay on for a couple minutes.
Let's not eat.
Just call Uber Eats.
I like to emphasize the couple of minutes.
Brother Boss, is there any way that you can
I'm sorry?
clear? Any way that you can clear?
Yeah, I can clear. Let me just stop the recording.